So as you have clearly seen that even after revascularization, the mortality continues to be as high as 50%. So the management after revascularization becomes very, very important. And to speak on this, we have a very bright young speaker, Dr. Soumik Choudhury. And I think he can tell us more about how we should manage these patients after Dr. Ashfaq has done a successful revascularization in this patient.
Thank you, sir. Thank you very much. Thank you to CSI, Shubhro sir, Devanu sir, obviously I work with sir, and Shubhanan sir, Sunil Zira sir, I think is also here. Thank you very much for giving me this opportunity. And actually, when I first got the topic, I was a bit confused. Which approach should I take for this? Because post revascularization management could mean anything from here to here. Where do I go? What do I do? First, I thought, should I just talk about the initial part, the part where we talk about the inotropic support and all? But then I thought that would pretty much, I would be repeating what Gopal has said. If I go for mechanical, I will be repeating what Ashfaq has said. So I decided to take a slightly different approach. I looked at, okay, the initial medical management has been done. The cardiogenic shock has been improved. The revascularization has been done along with the mechanical support. But is that it? Should we be satisfied with just the revascularization and the mechanical improvement in the BP? Or what are the methods, what are the medications, what are the guideline-directed therapy that we have to improve the short-term as well as the long-term outcome of this patient? Our target is not just to get this patient out of the initial cardiogenic shock. Of course, we must do that, but we also need to improve his long-term outcomes. We need to understand what we can start in hospital, what are the guideline-directed therapies that are probably now advisable to be done right in the initial index phase and not to be done later. What does the data say? And more importantly, when to start what? That is the approach I decided to look at in these patients. And I'm sure there are multiple other approaches that could be thought of that we could discuss in our discussion. So keeping this approach in mind, I would start my slides, and I hope it's visible. Yeah. So we are looking at the post-revascularization management of this patient. The medical management has been done excellently by Gopal. And I reiterate what Devanu sir said. Excellently, he explained it very well. Ashfaq, as always, was brilliant in talking about the mechanical approach and the revascularization. So now my patient has been revascularized. I don't know what happened to him after revascularization, so I had to make a few assumptions in the beginning about the revascularization part, provided, I assume it's successful, but there is the life beyond the stent. The stenting or the revascularization might not be the be-all and end-all. So how do we go further than that? So there are some assumptions, as I said, I have made fair and unfair. The first one, obviously, that the patient has survived the revascularization and the cardiogenic shock. Otherwise, everything we discuss is a moot point here. Secondly, a patient 2 days after anteroseptal myocardial infarction presenting in such critical cardiogenic shock, I think it's a fair assumption to say this patient is going to be in HFrEF. The patient is going to have a reduced ejection fraction going forward. The cardiogenic shock does point towards this. But with the excellent support that Gopal and Ashfaq have given, the patient has surely started improving. He may be still requiring inotropic support with the injectable diuretics, but there is a light at the end of the tunnel. We have gotten him out of the first acute part, but we need to get him going further. We need to add quality and quantity of life, and that's where we need to look at a certain group of medications, which probably are very important in the post-revascularization phase. Now, one of the key things that I looked at in this context was the fact that this patient, if you notice, actually presented 2 days after the initial index event, the anteroseptal MI. That worsened him, no doubt about that. But the fact remained that a lot of these patients do not come to a tertiary center first. They would probably be seen at a primary or a periphery center. It takes time for them to reach us. So one of the very important considerations that comes in at the end of the day is, how do I continue his initial and long-term antiplatelet therapy? Well, the revascularization is complete. Now I need to go further. Which antiplatelet, how long, how critical is it to decide the antiplatelet? See, there has been a number of trials, and you see, initially aspirin not much, I would say it's more of a historical rather than evidential based. Ticlodipine, clopidogrel, yes, still I think a few years back the most prevalent P2Y12 inhibitor that we use. But start looking at the data that really ticagrelor brought in. And why I talk about it is because a lot of these patients come in loaded with clopidogrel alone. Now, it would seem like a simple method to just continue that therapy, but if we want a significant beneficial outcome, an outcome which is superior, not just non-inferior, if you're looking at preventing the CV deaths, MIs going forward, we need to make sure our patient is also on the antiplatelet. That should ideally be of choice. The medical management has been done, the surgical management has been done, the mechanical supports have been done. But at the end of the day, it's also extremely important for our optimization of therapy to occur. Even if your patient is or was loaded with clopidogrel, it's extremely important that these patients should be on a ticagrelor setup as well. We are seeing the results. The results are very early. Within the first 30 days, you see the benefits and they are going up. So it's very important to also look at these parts of the therapy, post-revascularization and even pre-revascularization for that matter. If the patient is not on ticagrelor by then, I would say this patient should definitely be shifted to it, at least post-revascularization, because the mortality benefits are real. You have 21% reductions in CV deaths, recurrent MI, which are a reality, and a person who's presented initially with a cardiogenic shock, so sick, a recurrent MI is definitely what I would want to prevent, because I'm sure the ejection fraction is not going to be in the really good places. Now, going forward, 1 year, second P2Y12, 90 BD, I'm continuing. Do I stop it after a year? Do I think that's enough? Pegasus TME54 comes in at that point. Probably we could go further than this. We could even go up to 48 months, 3 years, 1 + 3 years beyond the post-revascularization, where the benefits with the ticagrelor 60 BD does not get overshown by the bleeding risks. Yeah, the bleeding is more increased, no doubt about that. But does that mean that we do not give it? No, because the fatal bleeds ICHs actually are similar. So keeping this context in mind, we need to basically think about where we are going further with the antiplatelet therapy. So ticagrelor 90 should be something that should be initiated in the post as well as the intravascularization period going forward for a better prognostic outcome. Now, beyond that, what I'm also looking at are my statins. Now, it might seem extremely counterintuitive to even discuss these things, but a lot of times the dosing is extremely inadequate because recurrence rates of a patient who's already had a CV event are quite high. Now, in these patients, you have in-hospitalized these patients, you have treated the primary cardiogenic shock, you have revascularized. It is extremely important for the post-revascularization phase to include your GDMT of choice. Now, when you're looking at a statin, what are you looking at? What is your milestone outcome that you're looking at? I am looking really at the LDL. Post-ACS, every 10 milligram rise or fall in the LDL is basically, it is oppositely, I would say, it has a negatively outcome on the ACS recurrence rates. In other words, every rise in the LDL of 10 milligram increases your composite CV or myocardial infarction risk by almost 9 or 10%. But if you can bring it down by every 10 milligram, that further decreases the secondary recurrent events. What are our milestones? What are we looking at? What are our targets? They're extremely important to know where we need to reach. And ESC 2019, and they agreed in ESC 2023 as well. Your target, this is the 19, which was early just before, which came out last month. 55 is your target after the ACS, because any patient, and this patient, as you know, is also a diabetic. That's why I'm trying to concentrate on the diabetic point as well. Regardless of the initial statin dosing, if at all the patient was getting, it's very important that we intensify and optimize as early as possible in the post-revascularization period the statin therapy as well. So these patients need to get a high dose statin as soon as possible. You're targeting LDL reduction of at least 50% from baseline, and your milestone that you want to reach is 50. If your patient has a recurrent event, then your milestone actually goes down to as low as 40. So this is very important to keep in mind, that any patient with an ACS automatically comes into a very high risk zone. It's a class 1A indication, whether statins are enough, whether you need to add ezetimibe, whether you need to add bempedoic acid, or as we say these days, whether we need to even think of going for injectables, right? PCSK9s in the beginning. That's a discussion for a different day. But starting LDLC intensive therapy right in the beginning in post-revascularization phase is extremely important. Now, what about beta blockers? Now, beta blockers are one of the cornerstones of therapy in these patients. Now, obviously, if my patient is still in cardiogenic shock, they're contraindicated. If you look at intravenous beta, it's a class 3 indication if the patient's in hypotension. But once your patient starts coming out of hypotension, the BP is settling down, the inotropic support has probably gone down or even disappeared, we must be really keen, alert, and awake to the concept of starting beta blockers as early as possible. We expect the ejection fraction will probably be low in these patients. So unless your patient has absolute contraindication, we did talk about hypertension, acute heart failure, AV block. Once your patient comes out of this, in hospital, oral treatment with beta blockers is a class 1A indication if your patient's EF is less than 40%. However, injectable beta blockers, until and unless your systolic blood pressure is more than 120, which it was not in this patient, would not be a primary I would be using in these patients. But oral treatment with beta blockers, definitely. Now, one interesting question comes. What about patients who do not have an EF less than 40%? In those patients, is it also a class 1 indication to go for beta blockers? Actually not so. You see, the data on patients who have an EF more than 40% is a bit scanty. The only real data that's there is a very small open label trial called Capital RCT, where they looked at about 800 STEMI patients with a preserved LV ejection fraction given to carvedilol, and they found there was no significant really outcome difference in both these groups when carvedilol was added. But this was an underpowered trial, and in fact, there are 4 large trials right now which are ongoing, and this is ESC 2023 data. There are large 4 trials ongoing. There's Reboot CNIC, which basically looks at ACS patients with LV ejection fraction more than 40%. There's Reduced Sweetheart, that's even higher, more than 50%. There's the Beta-MI trial, the Beta-MI trial, where there's no LV systolic dysfunction. And finally, the Dan Block trial, where they look at ejection fraction more than 40%. So let's look at how this data comes in and where we could actually put in beta blockers, even in patients who have an ejection fraction more than 40%, provided the initial hypertension and or if their AV block or dysfunction, AV blocks have been settled. Now, obviously, if you're talking about patients with an ejection fraction which is low post-MI and all, we will be talking about 2 drugs that's going to come in the discussion. We're going to be talking about SGLT2s. We're going to be talking about ARNI. Where do we fit them in? When do we start them? Do we at all start them? What about SGLT2s? Now, see, the theory makes sense. If you look at animal models of MI, the whole transient SGLT2 expression in ischemic heart, although SGLT2 receptors are not present in the heart, but there are transient expressions in the ischemic heart, that the adverse remodeling. So it actually makes sense that SGLT2s probably would be very useful in this group of patients. In an acute MI status, once you have settled the patient, you should be thinking of starting. But does the data really bear this out? And here I will actually look at 2 trials. One is very specific to this. The other I would like to look at more as a general guideline. So the EMI trial actually is the trial that really makes a little bit of sense, where they looked at empagliflozin in patients with acute MI. Acute MI patients in hospital is a double-blinded study where they started the empagliflozin in hospital in the acute MI patients and followed up for about 6 months. It was a randomized double-blinded trial. So what were they looking at? They were looking at diabetic patients, yes or no. So it could be a non-diabetic as well. They gave placebo versus EMPA, and the primary endpoint was NT-proBNP levels at 6 months. But they also looked at EF improvements. They looked at end-diastolic volume and end-systolic. So basically, the negative remodeling, whether we were improving it or not. And the results were actually quite encouraging. The NT-proBNP concentrations decreased in both groups without a doubt, but significantly more if you started SGLT2s, even in the acute MI status, in acute MI patients in hospital. A significant reduction over and above the reduction that you are getting in the placebo group. So basically, and this is actually where the reduction we are looking at, it happened quite early, actually, within about 5 to 6 weeks, you are getting the improvement. Within 26 weeks, you had a significant improvement. What about echocardiographic functions? LV end-diastolic volume, the LV ejection fraction, EDV, EDS, all of them showed actually significant improvements if you started empagliflozin. So SGLT2, yeah, I'll just be finishing in 2 minutes. Yeah. So SGLT2s, without really worrying so much about the, I would say, worrying about whether we could start them in hospital, and the ME data really actually helped us think maybe these patients, once we got them out of the cardiogenic shock, we should be even looking at starting at them for their long-term outcomes. So the post-revascularization management should include the SGLT2 once you have stabilized the patient. And this is actually the graphical data for that. Now, so as I said, the EMPA does make sense. You give it along with your post-MI treatment, and you have a better outcome of NT-proBNP reduction over 26 weeks. The other data that I look at slightly is actually the EMPULSE data. Now, I agree, the EMPULSE data did not look at MIs. They looked at acute heart failure patients. But the EMPULSE actually gave a bit of criteria, and I think this makes sense if you correlate to your ME data and MI patients. So please keep these 4 points in mind before you start your patient on an SGLT2, especially a cardiogenic shock patient. A systolic BP more than 100 and no hypotension in the last 6 hours, no increase in the IV diuretic dose for 6 hours before you start the drug, no IV vasodilators including nitrates in the last 6 hours, and no inotropes in the last 24 hours. If these parameters are met, if the cardiogenic shock settles, we should be thinking of starting SGLT2s even in the hospital setup. The data does bear this out. All-cause mortality, heart failure events further reduced. Now, what about ARNI? Is it suitable in the post-MI period? Now, we know that RAS inhibition, AC inhibitors, regardless of etiology of heart failure, HFrEF patients, they have shown improvement. Now, ARNI, as Paradigm HF said, showed over and above improvement over AC inhibitors. But the Paradise MI trial was a bit of a dampener. In the Paradise MI trials, within 1 to 7 days of the ACS, they did start ARNI, provided the patient's BP had settled and there was no inotropic support in the last 24 hours. But it was not shown to have a significant improvement over AC inhibitors. So as of this moment, starting an ARNI over an AC inhibitor does not bear out with the data. Chronic HF is a different discussion altogether, but in an acute MI setup, Paradise MI really did not point out to that. And this is basically the outcome data that we showed there were no significant improvements. And finally, MRAs, should we use them in the acute heart failure setup? Recent MI in the last 7 days with an LV dysfunction, with either symptoms of heart failure, diabetes, eplerenone, this was the FSS study, actually showed improvement, reduced mortality. So if your patient has no contraindications for starting a MRA, you should be also thinking about starting a MRA in the post-revascularization state. And the reminder trial in acute STEMI patients without heart failure, once heart failure has settled down, starting eplerenone, especially when EF was less than 40, had better outcomes. So to conclude, revascularization absolutely is the key to initial hemodynamic stabilization, but it's not the end. Adequate assessment of the EF, volume assessment, early initiation of the GDMT as appropriate for this patient with optimization of the available resources and device therapies, actually the key to a good prognostic outcome. Cardiogenic shock must be managed by medical and revascularization techniques. But once it settles, we should not forget GDMT for a better outcome in these patients. With this, I think I'll conclude here today. I hope in time. Thank you.
Thank you, Dr. Soumik Choudhury. I think that was a very nice presentation of what we are doing now and what we should do now and what we can expect in the near future.